Welcome to another edition of Facebook Focus. My name is Hussein Kermali. I'm the Chief Medical Officer here at St. Mary's Hospital in Waterbury, Connecticut. Each month we like to showcase one of our new clinical areas in medicine that we're able to offer to the patients and community here in Waterbury. This month we're actually focusing on something that's not new here in Waterbury, but wanted to reach out and connect all of us with a good friend of mine, Dr. Ken Matsuo. He's our Director of Hospital Medicine and our Hospitalist team. Ken, thank you for joining us.
Good to be here.
So, Hospitalist Medicine, in brief, really a collaborative team focused really on the inpatient side of medicine, taking care of patients after they have been admitted into the hospital, and collaborating truly with all the different providers, providing that high quality care and safe care that's important. So thank you again, Ken, for taking some time to sit down. Before we get into the discussion, tell us a little bit about yourself, your journey in medicine, and what brought you to St. Mary's Hospital.
Sure. So I attended St. George's University for medical school. I did most of my clinical rotations in Queens.
Okay.
And then I came out to Long Island, Stony Brook University Hospital, where I did my residency in internal medicine.
Gotcha.
I am originally from Connecticut, so after residency, I moved back to Connecticut, joined St. Mary's Hospital now a little over 10 years ago.
Wow.
Been here since. In terms of hospitalist medicine and why I went into it, internal medicine is a very diverse field. It's got many subspecialties within it: cardiology, pulmonary, nephrology, infectious disease. When I was doing a master's program in physiology, I did some basic science research in cardiac ischemia. So naturally, coming into residency, I thought, I would be attracted to cardiology, and I was, but I was also very interested in all these other fields within medicine. And truthfully, my idea of the perfect physician or the ultimate doc was like a walking encyclopedia, someone who knew everything about every single thing. You could give this person a handful of symptoms, and they would pull out some very rare diagnoses that maybe they read about once in medical school. So that whole sense of wanting to know everything about all the fields was what really interested me in hospital medicine, because in hospital medicine you do draw from all sorts of fields. Of course, there are subspecialist consultants who can help you when you need more expertise, but ultimately you're bringing all of this knowledge to the table to help care for the patient. And really that's what we do every day as hospitalists. And I also do like puzzles and problem solving, and I think that is at the heart of what we do as hospitalists as well.
And many of what you just said resonates a lot with my journey as well, because as a hospitalist and an internal medicine physician, it was that whole puzzle idea, understanding the entire breadth of work for a patient. And many often I would find, the specialist would be like, well, that's this other problem, or that's that other problem. And you're like, and as physicians in internal medicine and hospitalist medicine, we get to respond to the specialists, yes, I'm already taking care of that, which was really exciting to me, because we truly provide that full wraparound care for the patient while they're here in the hospital.
Yeah, and I think also as a subspecialist, you're naturally more focused on your one organ, and as a hospitalist, you have to juggle all those competing priorities from different subspecialists sometimes, and figure out what's in the best interest of the patient in their ultimate goal.
Yeah. What was intriguing to me as I was making my journey, and I'm sure you ran into this, people will ask you, well, what kind of doctor are you? And I would say I'm a hospitalist, and they're like, what is that? So tell us a little bit about what exactly is a hospitalist, different than a cardiologist or a nephrologist or a kidney doctor. We take care of hospital patients. But tell us a little bit more about that.
Yeah, so a hospitalist really is a physician who focuses only on hospitalized patients, care of hospitalized patients, and provides general medical care for those patients. In the old days, your primary care physician used to come take care of you when you were admitted to the hospital.
Sure.
So what would happen is they would come and see you early in the morning, then they would rush off to their office and have to see a full day's worth of patients in their office.
Yeah.
So when you're in the hospital, something happened to you, something changed, something developed, no one was really around to respond quickly to those circumstances, and you were relying on nurses to call your primary care physician, who may be in the middle of seeing a patient and either unable to answer right away, or there was a delay in answering. And we realized that that was not really a sustainable model of care, where a primary care physician was managing both patients in the hospital and in their office.
Yeah.
And as patients are getting older, they're juggling more chronic medical conditions. They're on more medications, and they're becoming more what we call medically complex. And it was just not a sustainable situation for them to be doing both things at once. So that's kind of how our field came to be. And by the mid 90s, in fact, in 1996, two physicians at UCSF coined this term hospitalist to refer to these physicians who are primarily internal medicine trained, but focused only on caring for patients in the hospital. And we, in a lot of ways, we kind of supplant your primary care doc when you're admitted to the hospital. So from the moment the emergency room physician says that you're sick enough to require admission to the hospital, to the time you're discharged from the hospital, hospitalists are quarterbacking all of your care and guiding the management, coordinating with everyone else in the hospital.
So as we're talking about internal medicine doctors, so the transition from primary care physician seeing in the hospital to the hospital doctor seeing in the hospital, some patients would say, well, I would rather have my primary care doctor come to the hospital and see, and you've outlined the reasons why that can be a challenge. But how well versed am I, a physician, as a hospitalist, to understand all of those chronic medical issues? Or is there something really special about the hospital patient that we need to focus in on?
I think as the medical field becomes more complex and patients are becoming more complicated themselves and living longer, there are benefits to having physicians who are more focused on providing outpatient care versus those who are more focused and adept at dealing with medical issues that require hospital level of care. Hospitalists, basically from the moment you come in from the emergency room, we're there to diagnose your ailments and set forth a treatment plan, implement that treatment plan, collaborate with consultants when we need some expertise help. And along the way, we're constantly working alongside your bedside nurses, who are, extremely important in your care. We work alongside physical and occupational therapists, social workers, and care managers. And our entire aim is to get you through the hospital more efficiently, with better outcomes, and reduce the need for readmissions down the line. And that's been borne out in studies that looked at the old model versus hospitalist directed care.
And many of our internal medicine residencies provide a lot of inpatient care. So I remember in my internal medicine residency, we were in the hospital a lot, learning medicine, learning about the complexities of medicine, as compared to being in an outpatient arena, because that experience was in our clinic, but that wasn't an everyday thing unless you were on a clinic rotation. But seeing patients in a hospital was the bread and butter of our internal medicine residency, at least the way they've been formed at this point in time.
Yeah, and I think that's a lot of why hospital medicine has grown so significantly over the past few decades since the 90s, and why more and more residents are interested in becoming hospitalists after they graduate.
And in fact, now there's actually a fellowship in hospital medicine
Yes.
that's accredited and has its own pathway.
Board certification in that as well, yes.
Yeah. So, I mean, clearly a new field since the 90s when the term was coined, so less than 30 years old, and now continuing to clearly show its need to be a fellowship trained to some degree to gain that even further experience on how to manage truly the hospital patient, which is phenomenal. So let's talk about patients. So you said this collaboration, and you mentioned collaboration with the emergency room physician. Let's talk about that collaborative role that a hospitalist plays in managing a patient from the time they come into the emergency room. Are they the same ones that see you right away when you come into the emergency room, or when do they pick up the care, and then what happens after that?
So when you come to the emergency room, the first people you see are the emergency room staff and the emergency room physicians, and they're the ones who are on the front lines and trying to figure out, okay, what might be going on and how sick are you? Are you not so sick that maybe you're able to go home and get better at home? Or do you need to be hospitalized for further care or treatments or investigations? Once the emergency room physician makes that determination to admit you to the hospital, we get involved. They give us a call. They tell us what's going on with you.
Sure.
And then we come down to see you, and we may further refine the diagnosis, the working diagnosis that they may have, and order further testing or that could be blood work or imaging testing to figure out what's going on with you, and then implement a treatment plan for you to get you better. And as I alluded to earlier, we work alongside everyone else in the hospital, and really, the old days medicine tended to be a little bit paternalistic in terms of the physician was, directing everything, but nowadays it's a much more collaborative effort. So, I see myself as on a level playing field with the nurses and the respiratory therapists and the occupational and physical therapists and everyone else involved in getting you from admission to back out of the hospital, whether that be home ideally to continue recovery, or in some instances you may need to go to a convalescent home or a short-term rehab facility to get stronger before you return home. So we're there to quarterback and coordinate all of that for patients. And once once it comes time for discharge, then we create a synopsis of your entire stay here, from what brought you in the first place, the relevant testing results, your hospital course, and then we kind of outline what the next steps are. You may need some antibiotics going home to treat your infection, and then coordinate care after the hospital and return and transition your care back to your primary care physician. So hospitalists do manage all of that within the hospital, but once you leave the hospital, we don't have an ongoing clinical relationship with you.
Yeah, but a lot of that is that hand-off transitions of care that we're handing back to the primary care physician or the other specialists that may be similarly to sometimes your own cardiologist or your own lung doctor or your own kidney doctor may not be the one seeing you here in the hospital, but you're going to get transitioned back to your regular doctor when you leave the hospital.
Right. So our job is to make sure all of those issues, if they were affected in the hospital, are clear to your team of doctors when you leave the hospital. And we have close relationships with all our consultants, so we call them all the time or talk to them about your care.
Yeah.
So that we're all on the same page.
And so is it just one hospital in the one hospitalist per hospital? Like, are they covering all the patients? But clearly, well, it's a leading question because I know that's not the case. We've got a whole team here, which you're the director on. So tell us about more than that answer. Tell us about your team. Tell us about how they work together.
Yeah, so I oversee a group of 12 physicians and one APRN currently. We basically provide general internal medical care for hospitalized patients 24 hours a day, every day of the year. Your care plan is really delineated by a board-certified attending physician during the day, but we also have our colleagues at night that can respond to any acute developments while you're hospitalized. Our nighttime colleagues are also responsible for admitting new patients from the emergency room as well. So it's, we're here to provide care for you 24 hours a day.
And literally here in the hospital.
In the hospital, correct.
So our nocturnists, or what we refer to as nocturnists, the doctors at night, they're here all the time.
Correct.
So when you're hospitalized, there's not somebody going to come into the hospital. They're ready.
Or your primary care physician who's sleeping at home and may not be reachable overnight.
Right.
And hospital medicine is really growing in different ways as well. So that's the traditional hospitalist model where probably over 90% of us are primarily trained in internal medicine. I think a growing proportion within that 90% is also subspecialist trained. So we're seeing more of that nowadays where, fellowship trained cardiologists or nephrologists or infectious disease doctors may choose to practice general internal medicine and care only for hospitalized patients. We are also finding more and more of these subspecialist trained physicians who are providing specialty care within the hospital on, let's say, a dedicated neurology unit, like a stroke unit or a cardiology unit. And then the remaining, I would say 10% and growing percentage of physicians who are called hospitalists are not even trained in internal medicine at all, but are trained in surgical specialties like orthopedics or OBGYN, where, similar to those primary care models, juggling the office practice and caring for inpatients becoming, difficult, and so they're choosing to, have two separate collections of physicians caring for those patients.
And I think it's a transition towards something that provides increased safety for the patient. When I think about whether it's internal medicine hospitalists, surgical hospitalists, OBGYN hospitalists, cardiology hospitalists, I think I look to it as a transition towards safer care. When you're in the hospital, you're not here because of something that could be managed outside of the hospital. You're here clearly because there's a clinical need for you to be managed in a much more acute setting, that there's something that needs more regular antibiotics, more frequent treatments, more frequent monitoring, different imaging that needs to be done rapidly. And that requires then the ability to pivot, change, adjust course, or reinforce what's going on. Plus, as we're dealing with that acute issue, there might be something else that starts to creep up that's unbeknownst to everybody, or something new that develops. We all know the stories about somebody comes in for X and leaves with Y, or Y develops while they're here. But without having that specific dedicated clinician here available all the time, and sometimes in-house, it becomes really challenging. Like we've got, for example, here at St. Mary's, we've got our orthopedic trauma doctors who are here in-house, so that we're not relying on the orthopedist who is managing, an elective hip or an elective knee that they're already in the OR. We've got a team that's already dedicated, ready to go and manage that acute trauma here in the hospital. And that's sort of that transition to keep the patient safer, get their treatment started earlier, and time is of the essence. In neurology, stroke, we say time is brain. But for everything, we want to keep the patients back on get them on that treatment pathway much more effectively.
Yeah, quality is a big thing in medicine, and that's one of the things that hospitalist programs have demonstrated in the past, that we've been able to increase the quality of care that is provided by a hospital or a healthcare network. Mortality rates are lower when hospitalists, when you have a program that involves hospitalists taking care of inpatients. Infection rates are down, readmissions that we talked about, and generally care is more efficient. So, back when they first started studying this in the 90s, they found that patients were spending almost a day less in the hospital when hospitalists were managing their care. So that means one whole day less of you being exposed to, foreign environment, less risk of delirium or confusion that invariably happens with a lot of patients in the hospital, or when you take patients out of their regular environment.
But I think also it's more than just the improvement in days spent. It's quicker testing, that you're able to, if something comes in at 3 p.m. or at 6 p.m, after everybody's sort of done their day and is back at home, we still have a team that's still working on things. So if new information is provided at that point in time from the morning, we're able to take care of it in the evening. We don't have to wait until that whole other day to start reinvestigating or reviewing what has just happened.
Right. Yeah.
So, I look at hospital medicine. I loved the field. I still love the field. I think it's fascinating and a real benefit for patients here from a number of perspectives. Let's talk about one thing before we get to wrap up. Will a patient see the same physician for their entire duration of stay? Or how does that work if I'm here for an extended period of time? What does that look like?
Yeah, that's a good question. And I guess the answer would be, it depends how long you're in the hospital. Yeah. Generally speaking, and this is true of majority of hospitalist programs, that we usually work something like 7 days straight, regardless of weekends and holidays. So if you come in, let's say, on the first day we're on service, you will probably only see us. Yeah. And we'll be the people that admit you to the hospital and manage your care while you're here, and then end up discharging you back to your primary care physician. If you happen to come in at the tail end of our stint, then you may have us and then someone else who takes over after us. So we generally do 7 days in a row, and then we have some days off, and then we come back and do the same thing again.
So, and that transition, is it a new team? Is it a new practice? Is it the same people on the same
They are our colleagues.
Okay.
So, we communicate with them in terms of what's been going on and what the plan is going forward. Gotcha. So that they're able to smoothly take over and continue managing your care.
Wonderful, wonderful. And that to me is a real big piece of this. We're talking about continuity of care,
absolutely,
making sure things are smooth in that transition, and that's what your team is able to do.
Yes.
Great. So one last thing we like to leave everybody with all the time is that last pearl or nugget that you would like to share with our viewers, clinically related, otherwise, so that they can benefit from our conversation a little bit further.
Because our field came about as kind of supplanting the primary care physician's role, I think if you don't have a primary care physician, definitely get one. They are extremely important in your overall health. Besides the whole diet and exercise, preventative maintenance, all that stuff is very important. I think for the older patients, talk to your families and your primary care physician about advanced directives, because sometimes that's something that we have to deal with in acute situation in hospitalized patients. And for us who don't really have that existing relationship with you or your family like a primary care physician may, those conversations are sometimes a little bit difficult. So definitely something to be proactive about and discuss ahead of time.
Those are two very strong points. Getting a primary care physician, and we're of course here at Trinity Health New England Medical Group able to accommodate that. But I think your second point about advanced directives, understanding your goals of care overall when you're healthy, and making sure that your wishes are understood and well outlined. Very effective when they're done when you're healthy, as opposed to having to manage them sometimes when you're very sick and not having all the decision points readily available in a quick amount of time. So
Right.
Fantastic. Thank you very much, and thank you all for joining us. We look forward to seeing you next time. Have a great afternoon.